Hello, my name is Dr. Jeff Sharon, and I am the director of the Balance and Fall Center here at UCSF. In this video, I'll be providing an overview of BPPV, which is a common cause of vertigo. We hope that you'll find this video helpful. First, let's go over some basic terms. BPPV stands for Benign Paroxysmal Positional Vertigo. Benign in this context means that it's not a life-threatening condition, such as a stroke. However, as anyone with BPPV will tell you, it's quite horrible, so benign may not quite be the right word to describe it. Furthermore, having BPPV does increase the risk of falls, and therefore does place you in some danger, in addition to the extreme discomfort of being dizzy. Paroxysmal refers to sudden and intense episodes, so it's describing the symptoms and the typical timing of the disease. This is true for BPPV, where symptoms will come on suddenly and feel quite intense. Positional, or some people say positioning, means that a change in position causes the symptoms to occur. We will review why that is the case. Finally, vertigo refers to the false or illusory sensation of movement of yourself or the environment when in fact no movement is actually occurring. Put all together, you end up with BPPV, or Benign Paroxysmal Positional Vertigo. Now, it's important to know that BPPV is one potential cause of vertigo. It's not the only cause. Some other common causes include vestibular migraine, Meniere's disease, and vestibular neuritis. Therefore, BPPV does not equal vertigo, and vertigo, which is a symptom, does not equal BPPV. In order to diagnose BPPV or any other cause of vertigo or dizziness, you should see a qualified healthcare provider. BPPV typically causes a sudden and intense feeling of spinning vertigo when the head position is changed relative to gravity. The two most provocative positions are rolling over in bed and looking up. BPPV has to be caused by a change in head position. Therefore, if you have vertigo that isn't triggered by certain positions, it's unlikely that you have BPPV. The vertigo with BPPV usually lasts seconds to minutes, and then it subsides. However, some patients will feel dizziness between episodes. BPPV does not typically cause other ear problems, such as hearing loss, tinnitus, or pressure in the ears. The inner ear, located deep within the skull, houses the organs of hearing and balance. The balance organs have two parts. The first pair of tiny organs sense gravity and the tilt of the head, and linear movements, such as accelerating in a car or going up and down in an elevator. In order to sense gravity, the inner ear uses heavy particles, crystals, which are called otoconia. They normally act similar to a plumb line, and microscopic sliding movements of a cluster of these crystals on top of specialized cells are able to be sensed, and therefore inform us about head movements relative to gravity. However, in BPPV, crystals are dislodged from their normal location and they end up in the wrong part of the inner ear, the semicircular canals. The three semicircular canals, 3 on each side of your head, sense quick head movements, like turning your head quickly to the side or up and down. When the dislodged crystals are located in the wrong place in the semicircular canals, they continue to float and move whenever we move our heads relative to gravity. But the microscopic fluid waves that these crystals cause as they tumble about activate the semicircular canal receptor, normally only activated by quick head turns. This causes the brain to think that you are turning very quickly, because of this false signal sent from the inner ear when in fact no motion is occurring. That is the cause of vertigo with BPPV. Now, it's important to know that while technically BPPV can affect any of the semicircular canals, including the superior canal, the horizontal canal, or the posterior canal. 95% of the time, the affected canal is the posterior canal. This is because the anatomy of the ear. If you look at the model here, you can see the cochlea, the organ of hearing, is in the front part of the inner ear, and the 3 semicircular canals are in the back. The most dependent portion is this part of the posterior canal. It's similar to the U-bend under a sink. Because of that, loose crystals within this part of the inner ear will tend to accumulate in the dependent portion over here, and that accounts for why posterior canal BPPV is the most common. Therefore, when people say BPPV, they usually mean posterior canal BPPV. We will discuss horizontal canal BPPV in another video series, but for now, just be aware that horizontal BPPV is very rare. Superior canal BPPV is even rarer, so that is not even going to merit its own video series. BPPV is diagnosed when you observe a typical pattern of rhythmic eye movements called nystagmus in the provocative position. Since the crystals cause a false sensation of movement, a reflex is activated where the eyes move in an opposite direction to the perceived head movement so as to try to keep your vision steady. But eyes can't rotate indefinitely, and therefore there is a quick corrective eye movement as well. The seesaw pattern of these 2 eye movements produce the nystagmus. The testing position for BPPV is called the Dix-Hallpike maneuver. This is where you turn your head 45 degrees to the right or to the left, and then you lean all the way back so that you're lying flat on your back with your head hanging below your body, usually by about 30 degrees. If you have BPPV, you should feel dizzy after a few seconds in that position, and an observer should be able to see the nystagmus. When you are looking straight ahead, the fast phase of the nystagmus will be directed upwards to the top of your head with a rotational component where the top of the eye will turn towards the ground. Therefore, if I had right posterior canal BPPV and I went into the right Dix-Hallpike position, my eyes would rotate like that. And this should be apparent to a trained medical professional and allow them to diagnose with certainty posterior canal BPPV. But before you do the Dix-Hallpike, it's important to know a few things. First of all, if you have neck problems such that you can't comfortably look up at the ceiling, or instability of your cervical spine, or any other neck or back problem, you should not do the Dix-Hallpike. This procedure involves extension of the neck, meaning moving it upwards, and lying flat on your back. Therefore, if you have any questions or any history of a neck or back problem, or any blood vessel problem affecting your brain, you should always have this procedure done in the presence of a qualified medical professional. Secondly, if you have BPPV, you will experience dizziness during the procedure. In some cases, nausea and vomiting can occur. Therefore, we don't recommend doing this test alone. We always believe that the initial diagnosis of BPPV should be made by a qualified healthcare provider. However, if you have confirmed BPPV in the past and it comes back, or if you are under the direct instructions of a qualified healthcare provider, we do think that home treatment is reasonable, provided that you do so in a safe and comfortable manner. Therefore, we have created a video series to try to help demonstrate the treatment maneuvers for BPPV. In the next few videos, you're going to see all of those maneuvers. This is not intended to replace the advice or the care of a medical professional. Instead, it's intended to supplement your office visit by providing you with a reference so that you can perform any maneuvers that you were instructed to perform at home. We do not, again, recommend that you self-diagnose BPPV. There are some causes of dizziness and vertigo that can be quite serious, such as having a stroke, and we would not want you to miss out on any necessary medical treatments. In addition, you need to know which side is affected for the proper treatment of BPPV. The maneuvers for each side are mirror images of each other. Therefore, your medical provider should be able to tell you which side your BPPV was on and which maneuver you should be doing. We are going to discuss several different maneuvers, and we hope that this will provide a useful online reference for you. However, it's important to know that the Epley maneuver seems to be, based on available scientific evidence, to the most effective treatment maneuver for BPPV. Therefore, you should know that almost all of the time BPPV is really in the posterior canal, and almost all of the time it should be treated with the Epley maneuver. There are some rare exceptions to that, but that is the general overview. Sometimes patients ask us, are there any other treatments for BPPV other than the Epley maneuver? We strongly believe that the Epley is the best treatment for BPPV. Medications are not effective for BPPV, and the particle repositioning maneuvers are much more effective. The exception to that is there are some patients who are in the minority who cannot get through doing the treatment maneuver, the Epley, without medications to suppress the vestibular system. This can be meclizine or benzodiazepines like Valium. Surgery is effective for BPPV, but it is only used as a last resort. Luckily, the repositioning maneuvers are so effective that we almost never have to resort to surgery. We do not routinely recommend any restrictions after doing the Epley maneuver, such as holding your head a certain way or sleeping a certain way. There are some conditions that can predispose to BPPV, including head trauma, vestibular neuritis, Meniere's disease, and migraine. Of course, if you find that you are doing these maneuvers at home as instructed by a qualified medical provider and you aren't getting any better or things are getting worse, we recommend that you follow up with your medical provider. We hope that you have found this information to be useful.